Good morning, everyone. We'll go ahead and call the Governor's EMS and Trauma Advisory Council Education Committee to order. Roll call first. Jody Harvard here. Deidre Blankenship.
Present.
Jay Cloud. John Creech.
Here.
Dr. Gonzalez. Present. Greg LeMay. Lori Lefevers. Wade Olson.
Here.
Dr. Radley.
Here.
Oscar Salazar.
Here.
Kelly Weller.
Yeah.
We do have three members absent, but we do have a quorum. Jay was unable to get off shift today. Greg had something come up at the last minute, and Lori had an illness in the family, so we knew they wouldn't be here today. So we'll go ahead and proceed on. Been kind of an active session. We've had 3 or 4 items on the agenda today. We'll move through these to get input. As far as I can see, we'll have no action items today. These are just things that are in continuum. We will continue meeting to work on them. Number 1 is development of advanced practice paramedic. I'm going to move that to a couple down just a little bit, so we'll spend most of our time there and at one other spot. Number 2 is stroke-specific continuing education objectives for EMS personnel for certification and recertification. If you've been to any of the meetings recently, you know this has been on medical directors, stroke committee, I think EMS, several others, looking at wanting to add content-specific continuing education hours. The thought was not to add hours, but to take some of the hours from the additional category for each certification licensure level and making some of those mandatory continuing education hours. When we spoke to the chair of the committee during the last meeting, I told him I thought right now the education committee's probably best thought would be is let's not look at hours, but let's look at content. What do you think EMS personnel, or what would you like them, if they would bring us some goals and objectives, we would certainly review those goals and objectives and make sure that we felt like the content was there with public input. But to say that one specific first responders or EMTs needed 2 hours and intermediates needed 3 and paramedics needed 4, I told them at this point I'm not sure if we're there or that's really what we would probably want to do right now, but to help and assist them with goals and objectives to make sure, because we know that stroke is becoming one of the leading causes. And the age group has certainly changed. Used to be those of us with gray hair were more susceptible. Now we have teenagers and even younger suffering strokes, and to make sure that we have provided the correct education recommended by AHA as well as other professional groups to make sure that we have that content in, I think is probably where we would probably shine and do the best. HT, are you here this morning? Good morning. Why don't you come on up and tell us what you are, I know you and the stroke committee have been looking at this, and we certainly want to help you develop whatever continuing education objectives you guys need. So kind of brief everybody and we'll go from there.
Okay, I'm HT Fillingham. I'm with the stroke committee. What we've been looking at, and quite honestly up until yesterday we kind of had one approach, but after the International Stroke met last week, that kind of changed our looks. We weren't quite aware of some of the things that apparently have been going on. To give you an idea why we're asking for some CE stuff, you know, Texas, in my book, leads the way in EMS. I put our guys up against anybody. We're not perfect, but we're pretty good, and we like being good. So a couple of studies that came out from the meeting last week indicated that EMS recognized stroke with very limited sensitivity. In California, they diagnosed a stroke pre-hospital 60% of the time. Okay. There are suggestions that we treat pre-hospital hypertension and stroke settings and not take them to the hospital. We start it in the field. They suggested we're probably not flying folks enough, moving them quickly enough. Medics were, in one study, were asked, what are the 2 things that you really need? And the first thing they said was more training on stroke and guidance in transport destinations. They're just, we're doing what we think is right. Cincinnati and Northern Kentucky, a study done there, they were taking them to their local first aid station and then transporting them out. And when they actually put numbers to the time, it took only 15 minutes more to get them to a comprehensive stroke center. Okay, well that kind of sounds like Texas in a way. I think we're doing that a lot in the country, and I think it's something we need to look at. But we have to have education to be able to understand this stuff, to recognize stroke, to formulate a transport plan that works in our system. Some of the things that were quite unusual and was shocking to me was that aphasia is not recognized as a stroke symptom nationwide. It was not listed by the medics. Okay, tell us what you see. Well, I see this, this, and this. It was not there. I don't know for us and for our group or where I'm from, you can't talk to us, we're having a stroke. We're gonna move on and do that. ED pre-notification of stroke symptoms via EMS is another problem. The EMS was not quite sure they had a stroke. They didn't want to call a code stroke or a stroke code pit stop type approach to something. But when we did that, the patient moved through the system much, much quicker. So what we would like is what we would suggest and recommend and ask your support for is including some stroke-specific CEs. We mentioned 1 to 4 hours. We just need to get started, okay? 1 hour is great. That's fine. Let's get something that helps us fine-tune our recognition of stroke, okay? Perhaps transport destinations need to be reviewed and looked at, and we've got to start a plan to do that for the system to work. EMS, Dr. Nicholas Sen, to paraphrase his statement, said, hey, the patient's outcome depends on the guy that first lays the bandage on him, and that's us, and we want to stay on top of the game. We're not asking to add additional time. I think that was misunderstood early. I don't like doing CEs more than anybody else, okay? I'm a licensed paramedic. I don't like doing them either. I have to. But I think having some stroke-specific content would push us way down the road, okay?
HT, you said 60% of strokes diagnosed were misdiagnosed.
The EMS, out of 10 patients, out of every 10 patients they transported that had stroke, only 6 of them were recognized pre-hospital.
So they're missing 40%.
Well,
Yeah.
40% of 4 out of 10 were having a stroke and didn't get recognized as having a stroke. Of course, when you miss aphasia, I'm not sure. Anyway, I laid it off to be in California, but you know, that's probably not true. That's probably a little everywhere. Sorry about that. Not Pennsylvania. But I think that, you know, there's some, these studies that came out last week significantly changed things in my book. Boys, we really need to get this going. We need some stroke stuff. Texas is, in my book, leads the way. Okay, I grew up in New Mexico. I could have stayed there. I grew up in Ruidoso. Okay, I could have stayed there. I came to Texas. I came to Texas because we have a system that works. I can call my medical director and we can talk about stuff in the field and we can make a decision. We can go. We couldn't do that before. Okay, I like that. That's what it's about. And I think Texas. I think we can very definitely lead the way, but I think we have to start somewhere, and I think now's the time.
Committee members?
I'm a little curious. Did they mention what type of education, the medics? Were they more specific?
Just stroke recognition. They simply said, well, I didn't see that as a stroke. And that's a little bit scary because, you know, in Texas, I really think we do a better job than that. But I don't think it hurts for us to make sure, you know, add an hour or two and fine tune it and make sure we're doing the right thing. And yeah, that's scary. I'm sorry.
Committee members?
And by the way, if you want to look at some of this stuff, the American Heart Association has put a bunch of these abstracts on their website. You can go read them yourself and get draw your own conclusions and stuff. I just touched the surface. There was a ton of them I didn't get to. So
That was my next question. Most of this is coming from AHA? Is that,
yes,
okay.
yes. It's on their website. It was Monday. There were pages of it.
So we're missing about 40% of the time we're missing the diagnosis of stroke with patients.
What the surveys are saying, yes.
And their recommendation is that we need more CE, more education, more training on recognition of stroke symptoms. Was there any correlation between the symptoms and the stroke centers as far as when we transport them to a stroke center, are we seeing higher outcomes versus when we're not?
In another study that was done, and we got a report on it yesterday, that when the system they would like to see us go to, and my understanding is there's a big push to do that, EMS has got to recognize it, they got to transport it, we've got to get it to a center that can do a CT and TPA them, and then we have to get them to a place that can suck that clot out. And if it's one in the same hospital, yay. If it's not, then we need not stop but continue going. But the outcomes with that, I think, were 60% of the folks walked away with normal life.
So it sounds very much like the old days
It sounds very promising.
when
yeah.
we had cardiac, when we were working on 12
Yes.
leads and getting those people to
Stents.
chest pain centers. Sounds very, very similar.
Yes, and
Okay.
that's what they're saying right now. And again, that's there's still a great deal of controversy about, does our system in Texas, can we do that? Do we have places we can go? I think our problem is for us to put them to a surgeon that can do something. It's a 2-hour ground transport and a 45-minute flight. And, I think we have to start looking at the way we're doing things as far as transporting and where we're going. The old adage of bring them to me and let me look and go, oh, yeah, you're right, he's having a stroke. Now what are we going to do? We've got to spend 3 hours getting an MOT to get him out. That's wrong. A lot of our smaller hospitals have CT capability and TPA capabilities, and I think we need to be putting those guys to work, but we need to not stop there to move on. So,
What is it? Can you tell us specifically? I know you want us to help and support. Specifically, what is it you'd like for us to do so we can? Would you like for us to start to look at this AHA data and start to go through it and make some
Sure,
recommendations
absolutely.
on? Okay.
I think that it would help if number one, you can support it and say, yeah, hey, I think we do need some CE stuff, okay? The number of hours and so forth, I'm leaving it. You guys are educators. What do we need, okay? You know what the programs are. You know what's going on out there. What's going to help us? If we're asking for help, if I'm your student and I'm saying, hey, I'm not getting this, I need some stroke stuff, what are you going to do? And I think that's what we would like, is to have your recommendation of, hey, let's look at this, let's look at this. We just want to get started on it. And one of the problems is that it's kind of drug on and drug on. We would really like to get, if you can, some support, and let's move this forward and get it going. The state, I think, is very agreeable to, if you present this to us, we'll get her done. So we just want to do the right thing.
What if I were to say that if you will work with me on coming up with what you want, because you're the content expert here, we put this together and do a recorded webinar that could be recorded and then linked and sent out? Would that be helpful to you? I don't know that they would be able to get official state CE for it, but it might encourage some recognition really quickly, and that's a 30 to 45 day fix.
Yeah.
That would at least get us going in the right direction for you.
Yeah, and again, I'm open to anything. After the conference last week and the things they came up with, how can you miss 40% of your stroke patients? That
Yeah.
just floors me. I mean, I've done this a long time, and maybe I've gotten a little complacent, but that, we're better than that in Texas.
Yeah.
And we need to move forward. Yeah, I'm open to anything. Yes, ma'am.
HT, could you get us the link to all this
Yes.
information? If you'll get it to me, let me share it with all the committee members. We can add it to our next work group between now and then. Give us time to kind of take
Sure.
a look at it and then start working on some recommendations and see what's out there. Everybody has their own training programs, and there are probably programs in this room that might already be doing this.
Right.
So for them it would just be a continuation, where for others it would be something new. So.
Right, and the intent is not to take away from any medical directors who have their own programs going.
Right.
It would be just, hey guys, put a little stroke in there, specific stuff, so we don't miss these patients. Make sure we know what we're looking for. We don't have that right now, and y'all are aware of that. There's, we've got medical, and it's kind of whatever, whenever, and we've got the little, however many hours down there that you can take whatever. If some of that we had to do, say in the medical area, were an hour stroke, that'd be awesome. That'd be a start, and I think it's going to change as time goes. I think as our system evolves and improves, I think we may see a need for other things. So.
Okay.
I'm curious.
Yes, sir.
This is for all levels of training, right?
Yes, sir.
Not just the paramedic.
No, sir. Some of the studies were strictly geared towards the paramedics because they were the ones who provided the advanced life support. Somebody somewhere decided that they were the only ones that can care for a stroke patient. We don't have that in Texas. We got BLS guys that need this, and we would like for it to be from ECA or first responder all the way up to medic. Everybody has to have an hour so we're all on the same page. My partner's a basic. We work together. I want her picking that up. We walk in a room, I want us to be on the same page, and I want her to go, and you see that? You pay attention, look at this, I can't do this. I want us to be on the same page to do that, and I think this is going to help us because we're getting the same CEs.
No, I agree with him.
Thank you.
Yeah, this has to reach all levels. This isn't just for medic. This has to be
it's
for
everybody. Yes, absolutely. Because there's too many BLS services in Texas, and we got to. They do a great job, and in some places that's all they got. And we want them to be the best they can be.
Well, and if you think about really what the major goal for EMS is for stroke care, it's detection.
Yes.
Early detection and appropriate destination transport. So I agree. It doesn't matter if you're an ECA, a first responder, a paramedic. You're detecting.
Right, and that's apparently, according to some of the studies, where we're missing the boat. So let's fix that.
Well, and we do need to. This has come up recently. So our screening tools. You know how we are as EMS providers. We love screening tools, right? Even in inpatient medicine, we do it. It makes it simple. We run through a checklist. So our screening tools are not good enough presently. So Texas wants to be a leader. We need to challenge each other. We need to challenge some of these large services to actually do some studies with some new stroke screening protocols.
Right.
It's hard to do the NIH stroke scale on the back of an ambulance. It'll take an hour and a half, but
right.
There might be something in between that we can look at. So that's
with some of our transport times, that's really. I'm afraid that's what's happening. We're not using those things. We're going to be there in 5 minutes and they're having a stroke. I don't know what they've got. It's not that. And we need to be more specific. You're right. And to me, Texas is a perfect place to do that. We got medical directors that want to take care of business and do the right thing. We've got educators that want to get us the information. This is the perfect place for that. We need to make that change. They can look at our stuff. Yeah.
Mr. Chairman,
Yes.
I just want to echo strong support for this, but I think we need to look at it as a system, not just an EMS. And I have a very personal story dealing with stroke, and I think people need to realize that it is a disease for the whole family, not just for that patient and what you put up with afterwards. But I think the best system works is when the medical director, the EMS, and the hospital work together to recognize the stroke and to ensure the patient gets to the right facility at the right time. And I was very, very much involved in a program up in the Allentown area, Lehigh Valley Medical Center, and I have emailed them since asking them for the research. It was going on when I left Pennsylvania to come to here, so we'll get to see, and it was a nice little triangle of everybody working together, recognizing strokes. I think being in this business long enough that we just blow it off and say, oh, it's a stroke. There's nothing we can do for you. And technology is changing. There is stuff we can do now. So I would support this as long as we also include the whole system into this, because if we recognize it and we go to a hospital and the patient stays there for 5 hours before anything happens, then we've defeated the whole idea of doing this.
Man.
I think that we have a responsibility to include everyone. Dudley, you here? Did I see you coming early? Hey, I think we need to talk to EMS. I think we need to talk to medical directors as we move forward on this one. This one will not be a short term. As usual, this will take a long-term process, and I think it has to be a process as we go through to make sure that we look at some provider needs, we look at some medical director needs. The education portion is long and tedious. Sometimes it's not hard to do, it's just long and tedious because you can either write the goal first and then do the objectives. You can write the objectives and try to find your goal. To do that, and I think that we're going to have to, as Dr. Radcliffe just mentioned, we need to find something that everybody's going to be able to use in order to push this forward. I certainly understand this. I'm from a little small town north of here, and in 1995, my mother suffered a major stroke, and I was working in a major medical center then, and I went to this outlying facility, and a lot of the questions when I walked in the door, no uniform, nothing on, just hi, me, and when you see your mom lying there, and you see the left-sided facial drooping and the weakness in the start speech, immediately you have to decide, are you going to be son or are you going to be clinician? Which one's easier to handle this because it's your family now? And I remember asking questions like, have we done a CT yet? And they're like, well, we have a mobile unit and it'll be here tomorrow. Not what I want to hear. Have we done a 12 lead? She has a cardiac history. No, but we'll get one done later. Okay. Did we draw any labs yet? Do we, no. We're just going to keep her comfortable. And finally, in Jody fashion, I just lost it and got my medical director on the phone and got a helicopter in the air, and they had no idea what happened as I took her out AMA and took her to a stroke center. And the nice thing about that was 21 days later, she walked out of that facility and renewed her driver's license. So for me, I look at stroke at what can and can't, and I think we have to look at our capabilities sometimes and say, just like we did with cardiac, we had to go through and say, do you have an interventional cath lab? No, but we have a diagnostic cath lab. Well, that's great. You can tell me we're having a heart attack and can't do anything about it. I just kind of see this almost taking that same path into finding out what our partners at hospitals can have and need. We can certainly look at this from an education standpoint, but I think we also need to look at some provider data. And certainly this will be driven a little differently for our rural and frontier partners where time, and we all know door to needle time is the same for cardiac as it is for stroke. So I think we'll just get started on this and get some partners, and we'll write some goals and objectives. And if the committee, is that pretty much your wish? Is that so that we head in that direction and assist our partners in stroke?
Yes.
Dr. Adler?
This is going to be an interesting turning point, the way I see maybe this happening. So I think as we increase our skill level and our expertise in different specific care areas, I think we're going to have additional people coming to this group saying, I think we need dedicated education in this area, in this area, in this area. And I guess I'm wondering, and this is just thinking out loud, is our Texas-based continuing education going to start to look more like that of our NR partners? So currently, like you said, it's really up to the CE program. I knew you were going to get up. I saw you festering over there. And, and at some point, are we going to be in a situation where we truly are decreeing that a certain amount of those hours will come in these certain areas? And if you look at the other, professional specialties like emergency medicine, we're required, whether you agree with the articles or not, we're required to look over 10 articles from a year period that are what our peers consider the hallmark educational articles. So, do we do the same for stroke updates on technology, things like that? But I think it's going to be interesting, and how that's going to shape us in terms of our Texas CE as we move forward. Maybe.
I would just say, and I'll give it to Jeff, where we're going through this process, keep in mind EMS is still the first, and if we mess up, the whole system's going to go down. Just keep in mind that I think this is going to be super beneficial however we decide to do it, there may be a million ways that we've just never thought about or never tried that we can get this done, but I think it's important to keep it in mind that we're the first cog, and if we break, the system's going to break.
When we first started talking about this earlier, if you all remember, for me, I was saying time is really not the issue here, and I'm not sure if this group wants to look at time or saying this is a specific CE that you have to have, because I do agree with what Dr. Adleff said, that, you know, next we'll have a different groups, and before we know it, that additional hours will be whittled down to 0 because we will have taken all. That being said, we still need to make sure that there's some education out there that's available for all of our partners, and how that's done is up to each medical director. But I think saying it's available and here's something you need to look at that we've kind of vetted through this group and through others, say here's something that you need, fine. I think once we start looking at trying to designate hours, I don't know, I'm with Dr. Adleff there, I think that might change the whole balance of what we're really trying to do. But to make sure we have some specific education, boy, I need more coffee, to have specific education, committee, would you agree? That's what we're here for, is to try to help when someone has an education issue and say, fine, let's have it, let's put it out there, let's vet it, let's talk about it. So I'm kind of with him on that one. Dr. Beeson.
Jeff Beeson, A Stroke in the Making. I think the reality on the statistics are that stroke is the 4th leading cause of death in this country. And yet neither National Registry, state, I could go my entire paramedic career having never done any continuing education on stroke. It's not required. And so when we look at the problem is we miss the recognition. I get the systems of care that Joe's talking about, but if we don't recognize it, we are the first step. And so I think what HT and what the Stroke Committee, and now as I've researched and looked into it, the missing piece is there is literally no requirement for stroke. And you say, yes, people are going to come in with their own specific CE specialties, but this is the 4th leading cause of death in this country. You want to talk about the morbidity and the expense of strokes cost, that's the numbers are astronomical. And if anybody equals those numbers, then they should have some type of CE also. This is not adult, like Joe said. This is the pediatric population. I'm sure, I don't know their statistics, but I bet we miss more than 40% of pediatric strokes. And so we'll be talking about this in the medical director, but as a future stroke in the making, I am surprised that what an issue stroke is in this country, and that for EMS we do not have any specific stroke requirement in continuing education. And literally we could go our entire paramedic career, EMT career, without having any stroke continuing education.
Thank you, Dr. Beeson. Linda, good morning.
Good morning. Linda Dickerson, GETAC's public member. It's 4th in the United States. It's 2nd in the world. Not having stroke, when you come to my house, y'all have taught me, do the smile test. Can they smile? Can they say a simple sentence? Can they put their hands above their heads? You know, I expect the paramedic who comes, even if it's basic, for them to know at least the basics of stroke. And I want to be taken to a comprehensive center. If something happens to my husband that happens to your mother, and I have atrial fib, have had it since a child, I could have had a stroke as a child. This is really, really pretty basic. You need continuing ed for stroke, just like heart attack. So I think, and this education committee is a fabulous place to start it. And I know Joe can be very helpful in that. So please, I'm shocked that that's not a continuing ed. That would be like a dental hygienist not knowing how to floss. I mean, this is pretty basic, okay? Let's get some education required, please.
Any other public comment? Chief, good morning. How are you? Guys, we're going to have to learn how to floss, okay? We're going to have to learn how to floss.
I'm going to kind of take the other side. And not that I don't understand. I've actually had 2 TIAs myself, personally. So I certainly understand the importance of recognizing stroke. But I'm concerned that we're going to start getting so specific. Because she said we do, on heart attack, no, we don't have a specific hour for STEMI. We have cardiac. We have medical. And I know, yeah, you can go your whole career and never have stroke, but what the heck is the medical director doing if the paramedic went their entire career and never had any training on stroke? I mean, we require a QA program. We can put it in part of the QA that each agency has, that they're going to have a commitment to certain education. But I think when we start breaking down our CE so much, it's going to become so difficult. You know, especially when some of us have huge numbers and people are coming in at all different points of their 4-year renewal to try to make sure, well, they've got this hour and they've got this hour and they've got this hour. It's just going to become really overburdensome for a lot of the CE instruction to happen. So I don't disagree at all. I think it's critical information. And I think part of the confusion on destination is right now because we have, are they comprehensive? Are they not? Are they this or that? And we're kind of, things are changing so much right now that, yeah, I understand why medics are going, hey, we need some more education on this. We need some help with destination because right now things are a little confusing. But I think, you know, we're going to get that part straightened out, hopefully, you know. But I just really caution on starting to narrow down because I agree with what the doctor said. We're going to, well, this group wants an hour on this. You know, one of the other leading causes of death is accidents. Do we need an hour just on the damage that can be caused from MVCs? You know, do we need an hour just on STEMIs? Do we need an hour, you know, and we can whittle this down to the point that it's just going to make it overwhelming for agencies to do CE anymore.
Thank you. Dudley, good morning. I'm sorry.
I was going to say, Mr. Chairman, I wanted to point out I'm not against setting some of these hour requirements. I just think, as just mentioned, we have to be very careful if we decide to change that paradigm on how we do it and how we construct it. So, sorry.
Morning, Dudley.
Morning. I think a lot of times it seems that the easiest answer is to look at the mandated CE hours we have to do and just say, well, we need an additional 2 hours for this every 4 years, or we need an additional 8 hours of this every 4 years. And we just keep stacking it in and we keep compartmentalizing it. And in my opinion, I think we're actually doing a disservice to our agencies. Now, I'll agree, there are agencies out there that do not look at their data and they don't have any idea what their medics and EMTs can and cannot do. I'll agree with that. But there are a large number of agencies in this state that do that, and a large number that are getting better and better at it because of active involved medical directors and clinical departments that are pushing to do better. And one of the things I've not heard brought up here at all this morning, which is greatly distressing to me, is that Texas has mandated by law a stroke system in it. It's mandated that the RACs have to have stroke committees. It's mandated that they have to have a transportation plan. It's mandated that GETAC has a stroke committee to drive this stuff. And when I hear the stroke committee come out, and no offense, HT, I know the data's hard to come by, and they're struggling with that. There's legislation to try to get more money to help with the data collection. But when we're citing data from California to try to say that Texas needs help, I'm not willing to accept that. Our RAC meets monthly. Our RAC has a designated transport plan. Does every EMS agency in our RAC know where to take patients? No, but that's because of dunderheaded EMS directors that won't tell their medics what the deal's going on at STRAC. And any amount of CE you force that agency to buy from AHA or from any other entity out there and set their medics in front of a video and mind numb them to death is not going to fix that problem. So we need to get a little more creative. I think our RACs in Texas, if we approach the RAC chairs, could probably give us a better idea of what percentage of stroke patients are delivered by pre-hospital that are actually recognized as strokes by pre-hospital in Texas. Nobody's done it. You may not be able to publish that and do an article about it, but I think our RACs, several of our RACs probably have that data and would be more than willing to share it with us so we could really see it. Is that a similar problem here in Texas? Or is it a pinpoint problem with an agency or a RAC or a section of our state? HT is exactly right. We need to know where to take patients. Well, our RACs figured that out for trauma. And even though we occasionally take trauma patients to the wrong hospital and then they have to be transferred, we're going to do the same thing with stroke. So before we rush in saying, yep, 2 hours for, here's 2 more hours we're going to carve off for this one specific topic, whether or not, if your agency recognizes 110% of strokes, you still got to do 2 hours of stroke training, regardless of what else is going on. I think we're doing ourselves a disservice. My recommendation would be continue to push. I like the idea of you guys developing something, making that AHA stuff available for folks that are out there that don't have the in-house talent to be able to do this, or a region that is struggling to come up with something new. But I would engage the stroke system to really try to judge and guide us on how big this problem is, and then what is the best way to address it, other than just mandating another 2 hours out of my 4-year CE cycle that I've got to dedicate to something other than what my CE is showing we're having trouble with, or my QI is showing that we're having trouble with.
Thank you, Dudley. Dr. Moore, good morning.
I would be probably negligent if I didn't at least say a couple things. One is that I'm a medical director, and I have had a stroke. And now I have a tattoo that says, use TPA. Because my wife had to make that decision after I'd had status epilepticus for 20 minutes and was on blood thinners, 2 contraindications. And she said he's going to be pissed if he wakes up paralyzed. And she was right. I was pissed, but I wasn't paralyzed. So I think that's new. But we've also got to keep up with what's happening. Houston just did a study of 40 patients with wake-up strokes. What do you do with wake-up strokes? Nothing, right? Because you can't. But their study of 40 wake-up patients, where if you go ahead and give them TPA because they probably had the stroke right before that early hour in the morning, 50% of those were doing fine in 6 months if you gave them TPA with wake-up strokes. So if we need to write a protocol, we need to bring in all that data and change as change is happening. Maybe we need to petition National Registry to make those hours mandatory. They already make stuff mandatory in National Registry that I have yet to figure out why that every year you have to study, a topic that you never see. But strokes are all the time. So let's put it in National Registry, and that'll solve it for us, because these guys have to recertify anyhow.
Thank you, Dr. Moore. Any other public comment?
I'll just say that the registry is looking at their Con Ed requirements, and there is a new model coming.
Yeah.
So
I think you're talking about prescriptive CE. Is that?
Well, it's national continuity competency.
Yeah.
We had a national registry come talk to our folks about where they're moving their CE direction. There's going to be a national component, a local component, then a self-assessment so you can figure out where you're weak at. And so once this package rolls out in about August of 2015, 2016, when they roll this out, I think it'll give a medic for EMT a better picture of where you need to be. They'll set the national content that needs to be done on what trends and topics. The local medical director of the state can set what that content is, and then you'll have a self-assessment to help you gauge where you need to improve at. And I think that's the direction we need to move in when we're looking at that.
Thank you, Brett. Any public comment? Any other public comment, rather? Committee, what's your pleasure?
Mr. Chairman, I think we, in one of our past work group sessions, I think we decided as one of our goals, our strategic goals, that this committee would try and appraise literature and medical evidence, and we would try and make some recommendations on behalf of this committee for potential reading and education to our EMS community. I think this is a prime example of how we could do that without overstepping our bounds. We could try and appraise the literature and make available suggestions on some dedicated current stroke education topics and push that out to the state. I think that would be a great way to start.
Okay. Other committee members?
I agree with Dr. Ratcliffe. If we're missing 40%, then the time to start making some movement in the right direction to re-educating is now, not in a year, because that's people's lives, and even if we're just doing something, at least it's better than doing nothing. So maybe we should come back to our next work group meeting with some of this literature pulled together, and everybody bring it, and then we can discuss it there.
Committee, you've heard a couple of options. I think I'm hearing that we get the data, we start to examine the data, we start to look at options. And whether it was Linda or Dudley or Dr. Moore, everybody, this is going to be one of those sensitive topics because everybody has their own view on it. Certainly, I think if everybody was doing everything they were supposed to do, we wouldn't have any issues at all. But because we have absentee medical directors, we have certain RACs that work differently than others, we have certain groups that work differently than others. I think maybe one of the things we can do is just make sure we're filling in those gaps, wherever those gaps are. To me, this feels a little bit more like a gap analysis to look and see where the gaps are, not mandate, not push, but to look at everything out there. So I think I'm hearing from you all that we'll gather the data, bring it back to our next work group meeting, examine it from there, and then certainly this will take more than one or two meetings, but to kind of look at it and move it from there. Does that pretty much sum that up? Okay. All right. That's what we'll do. Item 3, education's lessons learned, recommendation, treatment for patients with communicable diseases. I keep looking for something that we did the last time, and forgive me while I'm punching a couple of buttons, but we, at our last meeting at McLennan Community College in Waco, we looked and we were trying to find what were those lessons learned from Ebola. I think now we can look back and we're probably looking at Ebola the same way we did. When y'all remember a little disease called SARS? And everybody got, oh my God, we got ramped up for SARS and it was just going to kill us and it's going to be horrible. Yeah, okay. Remember something called bird flu? Yeah. Equine and VNE, Venezuelan equine encephalitis. Oh, it's going to kill us all. Okay, yeah. H1N1. Oh, it's going to kill us all. And okay, yeah. She said Y2K. Yeah, that was going to shut us all down too. Y'all remember when all of our computers had that little sticker on them that we were Y2K compliant because the world was going to come to an end. We had Ebola, and we thought, oh my God, the world's going to come to an end. But what I think each one of these events that we live through does for us, it makes us better, because each of these is an on-site learning experience. We learn from them. We would not have done the things that we've done if we did not have those things happen. We just wouldn't have. We wouldn't be as prepared. I know that I had the opportunity to be in Joe's office when some of those questions were coming in from the public, and Joe will stop there because you and I some of them were just, wow, okay, wow, okay. And I think that we learn, and as long as we're learning from them, that's good. We had stakeholder input on those lessons learned, and we were trying to figure out if anyone was doing fit testing for those N95 masks, and were education programs requiring those for students, or were they providing those for students? And we know certain programs were fit testing and providing, and some were having them go get masks elsewhere. And Jane Dinsmore brought up a really interesting question, and she said, for a program like hers, which trying to get everybody touched at one time may be difficult, is there anyone out there who would actually fit test for EMS or fit test for students if you had a small private service that you weren't able to do that? And I think that was a question that we never really got answered. We just kind of looked and thought, okay, how can we protect our students? Can we have policies that say that if it's a known infectious disease, that the student not be involved in the treatment and transportation of that patient? Well, everyone doesn't live in an urban area where you have an engine, an ambulance, and 5 police cars there, so if something happens, you can put the student and take them back somewhere else. If it's just that ambulance and it's 30 minutes away, that student's going to have to stay at the scene or get in the back of the box. We had a lot of mock exposures. at Tarrant County College, we had a mock exposure that we treated as if it were real. Student was involved in getting ready to be involved in a patient care situation, and the medics were letting the student lead because it was their fifth semester, and the student, let's say, was very judicious in his exam process of this woman who was in a retirement center and was having vomiting and diarrhea, which we didn't think much about till we heard Ebola. How many calls did we make? Oh, it could be the flu, it could be this, it could be that. And students started to touch her again as he's assessing her, and the daughter shows up and says, "I think my mother has Ebola." Well, of course, that sets off some bells and whistles, and the team leader at that point said, "Ma'am, why do you think that?" She said, "Well, the cook here at the nursing home, he just came back from Africa recently." Now, I don't know if that means much to you, but in order to get that, you're going to have something else. But at the same time, they took that student out of the room, they deconned the student, they brought another ambulance in that was stripped down. Don't tell Dshs that they stripped it down, put the patient in it, and transported them to the hospital, transported the student, deconned the student. And we just kind of took it as a real one. That this happened, what were lessons learned? What did we do? We actually ended up changing a couple of policies. So pretty much that's what we were looking at, and that's what we were talking about, trying to figure out what lessons were learned. We had looking at policies for students who are exposed. Are those in place in your programs for your EMT as well as your paramedic students? What's your policy if a student does have an exposure? What's your follow-up plan? Probably the same that we would have if a student was stuck with a needle. What would you do with that student? Are you requiring insurance for them? Do they have to present insurance to you to show that, yes, I'm covered in case something does happen? Because we all know things happen. I can tell you last year at my house, we had 3 students who were stuck with needles. And we had to take care of those students just like we would any others. So part of our preceptor training was to make sure our preceptors know that if a student is ill or injured or stuck while on your box, we need you to turn them into a patient and take care of them as a patient, take them to the correct facilities and make sure they get the correct treatment. So those are just some of the things that we looked at and talked about in trying to find some lessons learned and recommendations of treatment for our students. Any public comment? Committee comment? Okay. I guess we will just continue with those as things pop up that we do learn. I think we learned that nausea, vomiting, and diarrhea in copious amounts no longer will just mask and the gloves be sufficient. So we will continue from there, and thank you. Item 4, creation and support of an EMS educator conference in 2015. One of the things that a lot of educators have been looking for, and they're constantly asking all of us, do you have any information on this? Do you have any information on that? We're trying to send people to websites. Sam Vance from the pediatric side of the house for the last 2 meetings has presented something from the pediatric side for CE, whether it's a website or some information, something that we can disseminate to the public. So there's a need there. We see it all the time for good information and a place for educators to get together. So the same people that do the EMS conference for us been working on something, and there's some save the date cards that'll be coming out, and it's called Texas EMS Educators Summit 2015. This will be held in Corpus Christi. Yeah. We'll be looking together to try to shape some of the future of EMS education. We have a lot of people from a lot of input, but besides NAMC, and you look at Texas, a group for educators to come together to talk about those issues that affect educators. Other groups have theirs where they can talk about things that are specific to them, to have a group available to do that. The days will be Friday, April 10th, and Saturday, April 11th. April 10th will be the continuing education and attendee reception, And then Saturday, April 11th, will be continuing education. And I'm going to ask Joe or Brett to talk about the second component, and that is the DSHS coordinators update.
Thanks, Jody. We are going to try to help support this. The managers are planning, the 4 compliance managers are planning on coming out. We're going to talk about our course monitoring, our site surveys, our site visits, which is what we call them for the education, and our course records audits, and kind of give you an update what we're looking for, what we're doing. Since provider license has slowed down for us now, we're able to get out and do other things, use our time. We're not chasing all the new people around. So we hope to spend time with the educators, give you a good update, talk about what we're doing on our site visits, our course monitorings, and our course records audits.
We're really looking forward to this. This is something that's been in the making for a while, to try to just get some educators together in one spot. Some of you all remember that Texas EMS conference started off in a hotel over in the Sheraton, and it was about a room this size, and that was everybody there. And we look at what it is now. If you look at Eagles kind of started the same way too. It's a very small group of people, and that's grown to over 800 attendees. So we're kind of looking at this one, and hopefully in its infancy it will grow to be a wonderful adult later. EMS Educators Summit will include the course coordinators update, and the price is $225, or just the course coordinators update is $15. There are some special rates for hotels. They're still being worked out. I think it's pretty close on the money, but we're trying to make sure that we've got some hotel registration that will be online that will certainly be affordable, so that everyone that wants to come and everyone that can be involved will be. If you need some more information about this, Kelly, you want to have them contact you? Okay. If you need any more information, specifics that we haven't covered here today, feel free to contact Kelly Harrell. Again, we said it's the same people who's doing the Texas EMS conference will be doing this one, so we know it's being done correctly and being done right, and looking forward to a lot of participation from a lot of people. That's being done here. Now, that being said, committee, what are your thoughts on having a EMS educators symposium? Deidre, I see you.
I'm all for it. Spring break after spring break, kind of.
Okay.
I think it'd be great for us to get together and pull heads and not be distracted by other workshops and other stuff that's going on at a regular conference or.
Okay.
It's about time.
Okay, it's about time. Okay. Any other committee comment? Any public comment? Great. We're looking forward to that. We will certainly. I'm sorry.
If there's something that you would like for DSHS to talk about, if you could send that to me or if anybody, so we can make sure we cover anything that people want covered for us.
I think Kelly, help me out. I'm going to trying to do this from memory. We're going to have some test construction, test writing. We're going to do a clinical best practice summit, which will be a round table. We'll be looking at purchase versus homemade testing and curriculum development. What else am I missing? I know there's 5 or 6, and I can't do them all. Yeah, I'm trying to remember the other topics. We're also looking at community support, how you get your communities to support your programs. If you've had issues with faculty, issues with support from your council or however yours is set up, just some techniques and thoughts and ideas, because I think we are really good in EMS of taking care of patients. I think what we haven't probably done a great job, and this is, I'm just as guilty as everybody else, is making sure that the people that we work with, whoever our bosses are, whether it's city council or county commissioners or college or private entities, whatever, understand our mission and what we're really, really doing. I think sometimes we go, well, it's EMS, so come on, get behind it. Ready? Support. When sometimes we really haven't given them data. So we're just looking at this from an education side of topics and what can we do to actually garner some support and some help and move education forward. Jane, good morning.
Good morning. Jane Dinsmore, PERCOM. And maybe I'm the only one, just due to logistics, that I haven't been able to go to one of the COAMP's recent classes that they were doing on how to evaluate and build student proficiency projects. But I know they did some in several states, and they just did one in Dallas that I couldn't make. And when I asked them if they were going to do one at the Texas EMS conference, because when we were building all of this accreditation stuff, they were good about making presentations at the Texas EMS conference to help us, and they said no, they didn't have it on the agenda, had no intention of doing it. Is it possible, am I the only one who didn't get to go to one of these? And if not, is it possible that maybe we could get COA to do a thing on that too at this deal, since it's going to draw us all together in one place? Maybe I'm the only one, and I understand that if that's the case, but maybe I'm not.
We can ask.
Yeah,
Certainly ask. Certainly ask.
Chairman, I've already had the discussion. Jay knows this. We've asked them to come to do something in Texas. They are doing one in Dallas in a couple weeks or a week from now, whenever the date is. They make their schedule a year out. They assured me that they'll get back to us at the end of the year when they start scheduling their next year to do that. And so, I mean, we could ask again, but I asked as recent as last week, and they responded right back saying, "Hey, we have one in Dallas. We strongly encourage you to go to that one. I think it's coming up this week or sometime soon. Is it March 1st? March 5th. But that their schedule's set for this year, so they can't do another program for us, and they're not sure they would do another program in Texas since they already have one in Texas. So I just wanted to give you that update, sir.
Okay. If we can't get COA, maybe we can get some of the evaluators to come and talk about the process.
Sure.
If we can't get George or somebody else to come. So, okay. Great. Good information. We'll add that to that. Any other comment? None? Great. Good. Let's move to item 1, which we've got 32 minutes left in this allotted section. And that's development of the advanced practice community paramedic and community health paramedic curriculum. Jay Cloud, who had a job change and who's gone from an educator now to working a box, was heading that committee, and I know Jay's had great difficulty doing that. We asked Dr. Kelly Weller to step in and to look at what they have done. I'm going to ask her to present what we looked at in our last meeting, where we looked at how long that we have been looking and moving forward. Then at the end, I want to add one thing to what Dr. Weller has to help us continue our movement and growth in this direction.
Well, we spent quite a bit of our last work group meeting discussing and looking at this and trying to come up with some things to move forward. I think one of the questions has been, what exactly is it that our end goal needs to be? What is our real goal in working on this? We talked a lot about and listened a lot. We know that a lot of services are doing this. And for us to just decide what we're going to do doesn't respect their current efforts. I don't know that there's 100% way we're going to come up with something developed in a curriculum that's going to meet everyone's needs, because Texas is just so incredibly diverse. But we did come up with a couple of things to push forward, because we've been working on this for about a year, and I kind of feel like we haven't really, we heard a lot. We needed to say something back. So we came up with 3 statements. One is that the community health paramedic mobile integrated advanced practice has the purpose to reduce the occurrence or minimize medical crises, increase overall well-being of the patient, reduce the need for EMS response, decreasing time and money spent on the patient and taxpayers, decreasing ER visits and hospital stays, and support the overall community health. We just needed to find out what is the purpose of this thing. So we laid that purpose, and I think that's a great groundwork. We have to know what the point of this person that we're going to educate is. What is their purpose? Then we came up with the idea that the target audience for the community health paramedic, or the mobile integrated health care, or the advanced practice paramedic, whatever you want to call them, that target audience should be a paramedic level, but the scope of practice is dependent upon the medical director. So rather, that kind of helped us focus that we're not doing a scope of practice thing. We're not trying to limit anyone's scope of practice, but this is probably paramedic, and it's probably not an entry-level paramedic thing. It's probably not something that happens after initial education. It has to be something past initial education, and that kind of helped us focus as well. And then we've kind of decided that the partners and stakeholders for the community health paramedic, or this idea, are hospitals, clinics, pharmacies, community health services, medical supply vendors, nursing, EMS in general, social work, local government agencies, the LTAC facilities, rehabilitation facilities, home health agencies, hospice, education agencies, and EMS medical directors. And so that's our partners. And I think from here, there was a motion to move this information forward that was discussed, and so that's where we are. And I think what we're looking for now is what the next step is going to be. I don't know that we can write a curriculum at this point that's going to meet everyone's perfect needs, but I think that we're at a point now where we can really look at what the different agencies in the state are doing and try and start coming up with cobbling together some ideas of what these people need to know, because now we understand that this is not something that the initially educated paramedic is going to have. This is beyond that. And I think getting there was tough in making that decision. This can't be initial education, because one of my biggest concerns has been through all of this is that the minute we figure out the funding stream and the minute the money starts coming in, everybody who holds a paramedic certification is going to become one of these people, because there's going to be money to be made. And while that's great, it may not be in the best interest of the patients or of our stakeholders, because the initially educated paramedic doesn't understand some of the things that are going to be needed to be understood. So that's where we are, Jody.
Wonderful. As we have gone through this process, guys, there's a lot of input. And if you guys remember, when we first started this, we said 3 to 5 years, just trying to nail this down to get something that is workable. Let me... Sometimes Kelly would try to pull her hair out trying to come up with some definitions, and trying to, listening to a lot of people and finding a work group. And sometimes that's very difficult, because when you're working on a project like this, sometimes when we're here, I find people be a little less vocal, whereas we're in a work group in a smaller room, people are throwing out ideas. And that's, if I really want to get Dr. Ratliff riled up, we can do that in a small room, and he'll really start throwing out some good ideas, because it's something, during this work group, we had 3 whiteboards full of information. We were just going through, jotting down whatever was coming out, and then we could erase and start over and do that. On the front desk out front, there's a symposium. It's called Community Integrated Mobile Healthcare Symposium. I think Rick's here, Jennifer's here from Trauma Service Area E. They have been great partners, because as we would contact people, trying to get those people together to say, hi, come talk to us in Austin on this day, and then come again on this day, because we want to make sure we have a lot of access and people can find it and hear it. Because we wanted to get more than just us, because as Kelly said, this is something that's outside of initial ed. This has larger implications, and to try to get some of those folks together, because as we look at partnering with hospitals and primary care physicians and mental health and social work, and trying to get all of this done, I think together we're trying to create that great positive patient outcomes, create a healthcare system that's more efficient. If we can lower some cost, if we can work with avoiding some reducing readmissions, that's a huge thing. That's just huge And as we try to wrap our arms around it, we keep adding more partners and more people, and more opinions and ideas, and it just kind of grows and it morphs. I really appreciate North Central Texas Trauma Regional Advisory Council, TSAE, Melissa Christian, and Jennifer and Rick have worked really hard to help put this symposium together. It's going to be on April 24th of 2015 from 7 a.m. to 4:30 p.m. in the historic Uptown Theater in Grand Prairie, Texas. The flyers are out front. I think this is going to be really good because we couldn't get all the people here or every place that we wanted them, but they did an outstanding job of getting some people there that have some background to answer provider questions, to answer legal questions, to answer education questions, to answer consumer questions. Because again, as we looked at this, it just started growing. Christine Jenkins is the president of Dallas-Fort Worth Hospital Council and senior VP. We're going to get their opinion. Matt Savasky, who's director of public affairs from MedStar Mobile Health, and has actually written a book called Mobile Integrated Health. If you don't have a copy, Matt will actually have some there available that day. They've done a lot of groundwork. It's not the only work by any means. Jack Ayers Jr., if you've been in Texas and North Texas anytime, you remember Jack Ayers, who's a very big legal champion. Elizabeth Fagan, who's medical director for Baylor. Norm Seals, who's assistant chief from Dallas. Dr. Sharon Malone. Don Ziegler, who's the interim director of what's called Access Resource Center, which is part of community health at John Peter Smith. We have Chris Weinzapfel, who is the EMS director for Rowlett Fire. We've got Joshua Klaus, who works for a private service for community health service systems, and some of the topics that they're going to handle for us is hospital and EMS relationships in the era of EMS, how EMS-based mobile integrated health works, how to achieve the high triple aim, fire-based community, private, mobile health, because it's the right thing to do, looking at new level of customer service, living in the gap, legal insights in the realm of community medicine, and trying to bridge the gap between pre-hospital and hospital and then everything in between. So I think for this committee, when we would sit there, and guys, I'm serious, the last time we had 3 whiteboards full of information, trying to cull this information and trying to pull it together. And it's kind of like water in a bucket rolling downhill. The more you look, it sped up, and it just got more and more and more. And I really appreciate them for putting this together. I don't think they put it together for us, but they put it together to take care of some questions and thoughts. And anyone who can make it that day, like I said, the forms are out front. And I think that a lot of the questions that we have, if we can't answer them here, I think when you can get the content experts in one spot, you're able to ask all of your questions and get a lot of things done and get some of the answers. And I think live on their experience from places who've already done this, from people who've already started this, and let's see where the gaps are. I think this is a great time for gap analysis, for us to figure out if this is a topic we just need to stop and move on to something else, great. If it's one that we need to continue with, then we can continue with. And I think, again, kudos to them for getting all of these folks together in one spot for us to have a lot of questions answered. Committee, comments? Support, yes, no, good idea from the last time. I know that a lot of times you guys get here and you get stage fright because in the work group you guys have no problems talking. So don't worry, just imagine all of them naked and just go ahead and talk. Any public comment? I'll make sure that we have, I've got some extra flyers here. I think this is not only going to help Dr. Weller in her venue of writing and supporting and getting our target audience and make sure we have all of our stakeholders and everything involved, because Again, just trying to get this done, I think is just a momentous task. It rings of a lot of things that we tried to do in the past that we finally got done. But this one's just going to take a little bit longer, so we appreciate them. And this might be something else that when it's all done, we do somewhere else and do somewhere else and do somewhere else to try to make it as accessible to everybody as we possibly can. But right now, if you'll save the date, and that is April 24th from 7 to 4. One thing that might do, Wade, and I think from this committee we looked at coming to Amarillo in April. Might have to table it just 1 month. Instead of coming in, might have to move it 1 month just to make sure everybody has enough time. Also to the information, Justin Boyd sent me an email. He was unable to be here today, and a few days ago, Wade was able to get that information from him that we'd asked for at the last meeting. I think we might have gotten a little bit later, so I think giving us a little bit more time to work on it too might not be a bad idea. But just to let everybody know that's still on the table, and we will definitely be there and give everybody else time to move in that direction. Yeah. Number 5, review and update to strategic plan for the state of Texas. I think we'd already done that. We had written our portion July 18th and August 21st, where we had looked at the strategic plan. We'd made our notes. I've emailed those to Dr. Greenberg, and we had replaced and moved things around in most of the paragraphs to reflect 3 different areas. One, things that we had already done that could be taken out. Things that we were in the process of doing to either modify and show what we've done, and number 3, those things that were in the future and on the table that we were attempting to look at. And Dr. Radcliffe alluded to one earlier, and that was strategy A that we said we would replace with, we'll review and compile a list of pertinent evidence-based literature as it relates to EMS and make it available to the public. And that's what he was alluding to earlier when we were talking about strokes. It's the commitment of this committee to find information and get it out there. And I think what we've done in the past is something, it's just different, where we have taken information, and we don't mean to put it in a silo. I don't think we do. Well, here, I give it to her and she forgets to give it to somebody else. Now we live in this electronic age where you can pop something out there and everybody can see it. Doesn't have to be accurate, but everybody can see it. But whatever we can make available to the public. We moved some strategies around, and one of the other goals will be review and make recommendations regarding scope of practice, curriculum, education standards, and education process for Texas recognized emergency medical service personnel. Again, as we look at stroke, part of our commitment to continue on. Also replaced advocate for EMS, education system that utilizes innovative processes, addresses individual unique needs such as shift workers in rural areas for initial and continuing education for EMS certificates, license holders, providers in all areas of our state. We also added to promote cooperation between education and industry to provide adequate recommendation regarding progression in the standard of care, foster forward momentum in education using evidence-based medicine, and Texas EMS educators in conjunction with the RACs should explore innovative ways to educate healthcare professionals using technology to bridge the distance and time constraints of the barriers to EMS and trauma care education during GETAC meetings and other public forums. EMS educators should work with all systems in urban and rural areas and regions of the state. So we kind of started that today by partnering with the RAC and looking at the symposium coming up. And anybody else have any comments on item 5? That was the strategic plan update that we finished. Comments? None? Public? None? Moving on, last item, item 6, identify the list of accomplishments of this committee since its inception and report that back to GETAC. I had a copy of that. If you see me fidgeting up here this morning, I had it and I can't find it. I know it's on my iPad somewhere and I keep looking, and I apologize profusely for that. Normally we have it all together, and I know it's here, but it was a great list of accomplishments starting back from the inception. can anyone think of on this committee or from the public anything that we've done that we would want to add? This is going to the GETAC chair, Vance Riley, who requested that each committee list a long list of their accomplishments, and we had many, but can anyone just think of anything that it might be something that we've already done, but something else that you'd like to make sure gets on the list?
Did you add the Educator of the Year at EMS conference?
I did in 2011. Yes, ma'am. That's on there. Good morning, Leon. Come on up.
I just wonder, because I don't know what your list says, but the biggest accomplishment I saw when I was on the EMS committee was the group sessions between education, medical directors, and stuff, when we rewrote the rules 3 times.
Sure.
You know, when we did 132, 33, 34, 35, 49, we wrote all those rules, and then the legislation made it to 2 years, and we changed it over to 2 years, and then 6 months later, they changed it back to 4 years, we changed it back to 4 years. That was a big accomplishment. That was a lot of work. We traveled over the state, and the new education rules, the new recertification rules, and stuff that came out of that was a big ordeal.
You know what, Leon, I think that was probably the biggest for all of those committees that did travel around the state and talk to people. Again, you know, Texas is a big state, and sometimes I think electronic media is great, but sometimes there's nothing like you and I standing eye to eye, shaking hands, talking, and listening to others. So, yeah, I think that was.
Yeah, that's why I wanted to bring that up. I'll make sure that that is brought up, because that was like you said, from the concept, that was our job.
Yeah.
And we pulled that off.
Yes, we did. Absolutely. All of them did. Thank you.
Okay, thank you.
Any other public comment? Any other committee comment? Okay. We will do a summary of everything that we discussed here. We didn't have any action items. We'll move those forward. Any other announcements from the committee? I will say, too, in relationship to the save the date for the Educator Summit, and that's what we're actually calling it. You can also contact Kelly, you can contact me, or you can contact Jeff McDonald if you have any questions. But we're really looking forward to that. Kelly, are you in the room? Save the date cards coming out when? They're out there right. Quickly. Wow, quick. Thank you. Save the date cards are already on the table. Thank you. Thank you very, very much. So we've got lots of stuff out there too. You know, as I think sometimes we just become very robotic. We come into this seminar, we go outside, we sign our name, we walk in, we go through. But as I've watched the seminars increase, that table begins to increase with educational offerings out there, with lots of flyers from other people and other programs and things that are going on. So make sure that you all get one, take one, look at one, share it, so that everybody else has some information. Jennifer, good morning.
Good morning. Hi, Jennifer Gardner, RAC E. We have our NICTRAC mobile integrated healthcare and community paramedicine symposium on April 24th, as you discussed. Thank you. I think one thing that's really important is some of the speakers that will be there, Dr. Fagan, Daniel Frey, all from the McKinney area, and they're actually bringing forward what they took to the Institute for Healthcare Improvement annual conference, which was videos of patient testimonials to really see how that community paramedicine is impacting those patients in the community. So it's really going to be interesting, because not only do we see more of the C-suite executive kind of vantage from Assistant Fire Chief Norman Seals from Dallas Fire, but we also see the medics in the field and how all of that's being performed. So you guys are welcome, and we appreciate your support. Thank you.
Thank you. Any other announcements?
Mr. Chairman?
Yes, sir.
Just a couple here. Just a reminder that we're coming to the end. If you want to submit presentations at the EMS conference in Dallas this November, I'm sure Kelly's here if you have any questions about that. The online medical command course is still available. It's still free of charge until August, and you will be paying about $400 to take that course. and it is good for the doctors or a healthcare provider, an EMS provider can also take the course and get continuing education credits for it. And then there's the 3 AOR courses that are also coming up. There's going to be one in April 8th and 9th at the Texas Ambulance Association Conference in South Padre. There's going to be another one on June 3rd and 4th at San Angelo, put on by the RAC out there. And then in August, there's going to be one put on by the Texas EMS Alliance, and then we'll have one in November again. So there's a lot of good opportunities coming up, and they're all really good programs. Just reminders. But I will tell you that take that medical command course now. It is required for the doctors, and but anyone else can take it, but it will cost money after August, so it's still free. I'm sorry. Oh, and there is CE for the AOR course also.
CE for AOR courses as well as medical
The
director's
medical
course.
director course will count as CE2 for the AORs.
Okay.
Oh, that part. Okay.
Yeah. CE for everybody.
Across the board.
CE for everybody across
It's like bringing
the
food
board.
to a meeting.
It is. It is. You know, we have such great partners and a big group of people who are bringing a lot of education. Like I said, some of it's online, some of it's not. Supporting all of it's great. Yes, ma'am.
Thank you. Sorry, my foot is broken.
Oh, sorry.
Clarification on medical directors. Originally, it was not CME for physicians. So have you put that is now?
No, it is.
Okay.
It is not for they're required to take it.
Right.
The CEs state issued CEs. The other part is
Just making sure.
too
I heard you
expensive.
say everyone, and so I wanted to be very clear
Yep.
that it was not everyone.
Yep.
Because I'll have some irritated physicians.
Can't
And that
have
would be different from.
From the horse's mouth.
She just call you a horse? I'm sorry. Agenda items for next time, certainly item 1 will continue for a while. We'll add item 2, stroke and advanced practice. Number 3, education lessons learned. I think we can take that one off. Creation and support of EMS conference. We will have had our conference by the time we have our next meeting. Strategic plan can be omitted unless the chair decides there's something else we need to do, as well as item 6, list of accomplishments from the committee. Thank you guys for your input. Both of those from you are on the list. If anyone thinks of anything else, just yell at me before this time tomorrow. And that's the next one. Next meeting, because of coordinator's course that many of us are going to need to go to, going to need and have to go to, not sure about the next meeting date because we might have to. Can we just set that one, kind of email that one? Again, had planned to go to Amarillo, but if we're having a coordinator's course in the state and some of us are going to have to be there, still going to Amarillo, we just need to postpone a date. Well, say it and then.
Is there no way to do this during that conference? Because that would be like genius, because then I can make my boss pay for me to go to the conference.
Glad you brought that up, Jilly. I was waiting for someone to do that. There is a possibility that we could have a room before the conference and have our meeting the day before. That is certainly doable and certainly possible. I just need to see if committee members, if that would work for you, then that would be April 9th, that we would meet in Corpus.
I make a motion.
We have a motion and a second to have our meeting, our work group meeting on April 9th in Corpus. I've never had anyone make a motion to have a meeting before because it says Corpus on it. So we have a motion and a second. Any discussion? Any discussion? All those in favor, sign of aye.
Aye.
All those opposed, same sign. Our next meeting will be April 9th in Corpus Christi as a prelude to the Educator Summit and the Coordinator's Course. 9 to 3 work, guys. That's been our standard time. That gives everybody enough time for flights and moving around and not have to get up quite as early. I don't know. We'll find out. And
We're still waiting on location, Jody?
yes.
As far as the hotel location? TBA?
TBA on the hotel. There is a hotel that has been selected and working through the rate.
Okay.
Correct, Kelly? Okay. Because it's Corpus, you guys want to move this to later? Doesn't have to be 9 if you guys want to move it to the afternoon?
Yes.
Like 1 to 5? Okay. Is that going to do anything? No, because that's on the 10th. The reception's on the 10th, so yeah, okay. We got 4 minutes and 21 seconds.
You get to hear my allergy voice. There's a group in the hotel on Thursday, so I don't know what kind of rate we'll get if we can get that same rate on Thursday night. Believe me, we beg a lot. I'm used to that.
Wednesday night or Thursday night?
Either, if you want Wednesday and Thursday night, I can check. But I could probably get you another. There's another hotel that's not the same hotel, but I'm sure I can get you a really good rate at that hotel. And where did you want to have the meeting?
Can we?
The hotel.
Can we have it at the conference, at the selected conference?
Possibly.
Hotel? Yeah, that's what I was thinking. That way it's all in the same spot.
I can probably have an answer for you by tomorrow.
Okay.
So let me do some emailing, and I'll get back to you.
Okay. So, guys, we will go with April 9th, Corpus, 1 to 5, location TBA.
Cool.
That work? Okay.
Jody, I had a quick question. Did
Sure.
you ever discuss the age that Justin and stuff at the last meeting in Waco?
I'm sorry?
Did you ever talk about the age of the paramedics and EMTs at the last meeting?
Yes. Yes. It's, as far as trying to find them in the age and who's there and where they all going, yeah, that's going to be an ongoing. Yeah. Yeah. Any other comments? Thank you also very, very much for being here today. Appreciate everyone's comment. Need a motion to adjourn? Second? Yes, what? I'm sorry, Ryan.
It's too late, sir.
Yeah, I know it's not. It's
Got
not too late.
2:33.
All right, I don't even need 30 seconds. I think that after hearing the closing discussion on the community paramedicine, I just want to float something out for the 1,000-pound brains in the room to consider. I think the reason why we're having such a hard time defining the role is because we're not willing to set a bar. Nurses, when they went to advanced practice nursing, they set bars for CRNA. They set bars for nurse practitioners. If we're going to set the bar, we need to stop being disingenuous with naming it 3 different names. We need to set a bar. We need to come up with a means to attain that bar, and then you can set a curriculum. The biggest problem is that community paramedicine has so many different connotations that if we're ever going to get a funding stream, you have to nail it down to a specific set of skills. So I think that as we talk about this, we really have to look at all the other programs that have gone on to advanced practices or board certifications and start from there. So I just want.
Thank you.
Still move to adjourn.
Second.
Second, all those in favor? Aye. Thank you very much. We're done.